Hi, I will be talking about chronic lymphocytic leukemia slash small lymphocytic lymphoma, its tissue counterpart, in my third video of the series of WBC neoplasms. And here I will be talking about chronic lymphocytic leukemia, which is the most common leukemia in adults in the Western world. And just like you can see here, that chronic lymphocytic leukemia and small lymphocytic lymphoma are the part of the single entity. It can happen. It generally happens that the chronic lymphocytic leukemia that has presented here, it can progress and become small lymphocytic lymphoma. Though in the patient we can find both of these things in a patient. And it can also happen that the small lymphocytic lymphoma, which was originally presenting in the lymphoid tissues, that can become chronic lymphocytic leukemia. You may be understanding what I'm trying to say, that the lymphocyte which got mutated after it reached the lymphoid tissues, from there on it got out into the blood, and then it became leukemia. So the origin is basically a naive B cell and a memory B cell. I will tell you afterwards that why the origin is memory B cell, though I explained to you that it was a naive B cell in my previous videos, but I will tell you later on. The pathogenesis, there are 13q and 11q deletions which lead to decrease microRNA expression, which lead to the overexpression of BCL2. BCL2 is an anti-apoptotic protein which leads to the accumulation of mutations. What happens that when the cell is not undergoing apoptosis or has got immunity from apoptosis, when it starts accumulating mutations in its genetic structure, and though it takes some time, that is why you see it is presenting in adults. Why is it not, everything is related, why is it not presenting in children? Because it is a lymphocyte. It does not have an intrinsic capability to multiply very fast. So it has got one power, which is that it is having, you can say it has the power of BCL2, that it won't die and it can happily accumulate mutations. But that is what is happening, that this process takes some time. You just can't produce a full-fledged malignant cell which is also multiplying from a lymphocyte who has just got a mutation of BCL2. It takes some time. It also undergoes TP53 mutations, and that leads to all sorts of things and all the mutations which finally make it a full-fledged, you can say, multiplying malignant cell. So yes, the patient presents with the clinical features: fever, anorexia, loss of appetite, hepatosplenomegaly, lymph node enlargement, and weight loss. The weight loss will be can be drastic in some cases. Generally, it's very much. And then we do the investigation. So investigations we do to find out that our patient, so that to confirm that our patient is having CLL or SLL. So first of all, we do a peripheral blood smear, and here we see a lot of lymphocytes and smudge cells. We also call it a smear cell, but yes, smudge cells. So we see lymphocytes. You can see a large nucleus, scant cytoplasm, large nucleus, and lot of RBCs. And why do we see a smudge cell? You see, the logic behind this is that when you are having a lot of lymphocytes, these lymphocytes are not just normal in number. Generally, they are 20 to 50 into the power 9 per liter lymphocytes. That's so much, and generally the normal count is 4,000. I think not 4. Yes, 4,000 per microliter. Then you can say that no. This is per liter. So if you convert this, then it becomes 20,000 per microliter. And generally, normally, what is that? That normally 4,000, 1,000 to 4,000 microliter is there. So yes, this is what we see in chronic lymphocytic leukemia, and this is what we see in normal conditions. So you can see the you can say the deterioration that has taken place. So if there are a lot of lymphocytes, then what happens that these lymphocytes start infiltrating the lymph node. Now you see the lymph node is like a, you can say, a place where the B cells were coming, they were undergoing development, antigen presentation was going on. But minimally what happened that there were 5 to 20 B cells that used to enter there, but now there are thousands of B cells entering the lymph node at the same time. So what happens that when these huge amount of lymph node enter, some lymph nodes get crushed with each other. You see, the lymph node has afferent lymphatics, and these are very small, if a lot of lymph nodes start entering through this traffic, then they start crushing each other. So these crushed B cells or B cells which we see in the smear, these are the smudge cells which we see. So basically that's the reason we see smudge cells here. Now we can also do CBC just like I told you, and here we will see elevated lymphocyte count, which will be up to 20 to 50 uh, 20 to 50,000 per microliter. And you can also do lymph node biopsy, where you will get effaced lymph node architecture. I mean the lymph nodes. In the normal lymph node, you will see that there are circular lymphoid follicles. You can see here. You can properly demarcate them also. But here, in an abnormal lymph node biopsy, in a CLL patient, in a patient of CLL, you will see that you can't properly make out. I mean, I can make out a circle, but it's as if someone compressed the circle. This is a normal circle, but if I compress it, becomes something like this. So that is what I'm seeing there, that there's not a proper follicle that you can find out here, and the architecture is effaced. Now let me explain this a bit further. See, in the lymphoid follicles, generally there is a dark region here and a lighter region here. So the dark region outside are the mature naive B cells, just like I talked to you about, which become centroblast and centrocyte. So these mature B cells have heterochromatin. They don't express that much factors transcriptionally, because they are undergoing, just like I told you, that they don't have to produce antibodies now. They have to undergo a lot of DNA changes. That is why they activate that I told you about CD10 and BCL6, which repress them transcriptionally. That is why they are having a lot of heterochromatin, and heterochromatin generally takes a darker stain. That is why this appears dark and the germinal center appears light. Now here also you are saying follicles, but here there is a different case. These are not follicles. I mean, if they have become abnormal, they do look like somewhat like follicles. They try to imitate them, but they are not follicles. They are called pseudo follicles. And the darker region you see here are the mutated naive B cells. Though they are mutated, but since they are also having heterochromatin, so they appear dark. But since they are multiplying a lot also, they have effaced the architecture of the lymphoid follicle. For example, this was properly circular, but if I increase so many B cells, then they will start effacing the architecture. It won't be that organized structure. That is why you can see that there is proper effacement. You can't just make out, just like you see in this normal lymph node, you can see proper architecture of the lymphoid follicles. You can see primary follicle, secondary follicle, but here you can't make that out, and you can see a lighter region there. So what is happening there? What happens is that some malignant B cells, they start accumulating mutations and become even more, you can say, immature, and they gain a lot high multiplicative power. So these become the type of cell which we call prolymphocyte. And you see, if I zoom this lighter area here, then I get this. This is what we call, these are all prolymphocytes. You see, the chromatin is vesicular, and you can see a centrally placed nucleolus. Let me mark out here, centrally placed nucleolus here. So yes, these are prolymphocytes, and they have vesicular chromatin and 1 or 2 nucleoli. So basically they resemble like centroblast. I talked about centroblast and centrocyte, that they have multiple nucleoli and they multiply very much. So basically they resemble that, and these mature malignant naive B cells accumulate mutations, become even immature, gain a high amount of multiplicative power, and they become prolymphocytes, which are here. So you can see the beauty here, that the naive B cells are gaining mutations, are multiplying obviously, and becoming even more malignant, even more multiplicative, and then they are becoming prolymphocytes here. And here it was a different case. So you can see that normal and abnormality, though they are very distinctive, but are very same at the same time. So yes, that is in Robbins there is a line which is saying that we see a lot of proliferation centers in the lymphoid tissues. So this is what we call proliferation centers. These pseudo follicles are what they are called, proliferation centers. So yes, this is how we make out. And then we also see the bone marrow aspirate investigations, bone marrow aspirate. And in bone marrow aspiration we see a lot of these type of cells, lymphocytes, lot of lymphocytes, actually many of them, many naive B cells we see, hypercellularity, and the megakaryopoiesis, and the, you can say, the production of neutrophils and basophils is normal. But in end stages, when the naive B cells become very much malignant and they multiply very much, they even take the space of the other cells, then in later stages this leads to the progression to neutropenia and thrombocytopenia, which can lead to bleeding, purpura, and all sorts of bad things. Now if I talk about the immunohistochemistry, so yes, we do immunohistochemistry, which gives sure short diagnosis that yes, this thing is CLL or SLL. So basically when we do immunohistochemistry, then we get positive for CD19, CD20, CD5 and CD23. I just told you, it's all written here. In the previous videos you will see, then you will make an exact link of what is happening. So yes, CD19, CD20, CD5 and CD23. Now let me explain that why memory B cell. So in the marginal zone, sorry, not in the mantle zone, in the marginal zone, I talked that the B cell comes with an antigen, but there is one more cell that is present here in the marginal zone, and that is the memory B cell. Here I talked about, I told you that just when the centrocyte becomes a lymphoplasmacyte, it also becomes a memory B cell, and that memory B cell goes in the marginal zone, and from in there it stays. Actually what happened, that when scientists were finding out the mutations that what caused this leukemia, so they've also found out mutated Ig segments in some B cells, and sometimes they did not. So they made out that okay, if it is a mutated Ig segment, then it must be a cell which is it must be a B cell that has undergone development in the germinal center. Just like I told you that when we see mutated Ig segments, we can surely tell that yeah, he had come out of the gladiator match, which we talked about in the previous videos. So yes, that is why the memory B cell, and the memory B cell, that too because memory B cells are the only cells having mutated Ig segments which lie in the marginal zone. So yes, I explained to you. And just one more thing, that when all these mature lymphocytes, they become pro-lymphocyte and gain that appearance which is very similar to centroblast, and they multiply at a very high level, when this progression becomes too much, then this CLL becomes DLBCL, the most, you can say, aggressive neoplasm having the worst prognosis, diffuse large B cell lymphoma, about which we will talk in later videos, lymphoma. But yes, this is the end game here. Now let's talk about the prognosis. So and yes, this transformation is called Richter syndrome. When this happens, Richter syndrome. And the prognosis, so the prognosis is very bad when we have TP53 mutations in the cell. Also if there is you can say the worst outcome can be correlated when this becomes diffuse large B cell lymphoma. And also if we see notch 1 mutations, then that is also very bad. So yes, basically I covered what basics was required and all the problems which students generally get after seeing some terms in robbins. So yes, thank you.